see. We know this is the same on every slide. We've talked about open and closed fractures. So at this point, y'all should have an idea what our open and closed fractures are. Your dislocations and amputations, roughly the same. There's not a whole lot we can do in the field for the dislocations, but amputations, obviously, we should be able to try to control that and move forward. Click. All right, so we'll talk about the pathophysiology assessment and management when we're talking about upper and lower extremities during an orthopedic trauma. We'll talk about open fractures, closed fractures, dislocations, sprains and strains, pelvic fractures, amputations, and replantation. We know that one. So let's see here. Non-traumatic musculoskeletal disorders is a management of how to treat those non-traumatics. The human body is a well-designed system, which we all know how cool it is, in which is upright posture and the movement and provided with a muscular system that keeps us upright and keeps our posture by our bones. The system also protects very vital organs of the body. The musculoskeletal injuries are most common reasons why patients seek medical attention. Musculoskeletal injuries are often easily identified because of the pain, and we're not used to seeing them. They're pretty obvious. We don't have to ask a whole lot of questions. We can be like, oh, that doesn't look like it's in the right spot. You should be able to tell by swelling, the deformity. You should have warmness to the touch when you go to palpate the area. They're going to probably be guarding that area, but so be cautious. Although musculoskeletal system injuries are rarely fatal, they do often result in a short or long-term disability. Do not focus solely on that particular injury, but figure out if there's any other life-threatening issues that may come that's secondary because of the MOI, or primary. Maybe what you see initially is secondary, so don't let you just get blindsided and put your blinders on by that. So we know that we have three types of muscles. Whoa, wow. 3 types of muscles. We have the skeletal, smooth, and cardiac. I'm pretty sure y'all can guess where all of these are, specifically where the cardiac is. It's going to be around the heart. You're going to have your skeletal muscles. These are going to be more formed towards around the skeletal parts of the body, around the bones. That's what's going to hold the bones, the muscles to the bones. And then you have your smooth muscles. That's going to be on your intestines, more of your kidneys area, large and small intestines to help process that food and move it on its way. The skeletal muscle is also called a strained muscle because of its characteristics. The way that it looks and has those stripes, it's got these stripes that's straighted. It attaches the bones and usually across at least one joint. So if you can see right here how it brings it around on the back side of that joint, those are all skeletal muscles because it's around the bone. Called voluntary muscles because it's under direct voluntary control of the brain. So we know if it's part of the voluntary parts, we don't have to think about moving it. It automatically does it. Now, this skeletal muscle does make up the largest portion of the body's muscles. Probably would be a good test question if I was to write one. So all skeletal muscles are supplied with arteries, veins, and nerves. Skeletal muscles tissues is directly attached to the bone by tendons. So if you stress a tendon, you can have some muscle reflexivity. That's going to have some issues. As you'll be sore. You may have some bleeding. You'll probably have some bruising. So think about those too. So your smooth muscles, again, these are involuntary also. They perform the automatic work of the body. So these are found in walls and those tubular structures of the body, and it contracts and relaxes to control the movement of the contents within these structures. So again, we talk about around the large and small intestines. It helps process through there. You see how it'll have the lumen, it's a constricted area, and these just kind of like, the way that I remember these are like snakes. These move and it processes the food through the whole parts of the body. That's just the way that I process it and remember it. Sorry, y'all, my nose is still congested and running, so I'm trying to keep that caught up, so I apologize. So your cardiac muscle is specifically adapted involuntary muscle with its own regulatory system. So what's cool about this one is that the cardiac muscle, it regulates itself. It does it need more blood flow? Does it more friction? Does it need to go faster? How does that need to work? And it's all done within that muscle itself. So again, just think about how extra cool that is. Now the cardiac system and the muscles itself can function solely on just brain impulses, involuntary process that's done. To me, that is unbelievable. Just thinking about how freaking cool that is. On there's no Chris Wally doesn't have to think about that. All right, so the skeleton gives you our recognizable human form. It protects our vital internal organs and also allows us to move. Um, it's made up of approximately 206 bones. The bones are also produce blood cells in the bone marrow itself and serve as a reservoir for important minerals and electrolytes. So you can see here the human skeletal when we talk about the different parts. So it's 206 bones in there. I remember when I went through A&P, we had to number all those and know them. Whew, I think I memorized it, and there's no chance that I learned that. I know my big ones, but certain parts of the man, I couldn't tell you no more. Right? But so if you go that route, just be FYI, you may have to learn them again. All right, so the skull was a solid bolt-like structure, and it surrounds and protects the brain. So we know we have to have something there that protects our brain, that gives it its protector. It has its own built-in hat, and that's what the skull does. The thoracic cage protects the heart, lungs, and the great vessels. The lower ribs protect the liver and the spleen. The pectoral, which is your shoulder girdle, consists of 2 scapula and 2 clavicles. The scapula, which is the shoulder blade, is a flat triangular bone held to the rib cage by powerful muscles that buffer it against injury. So the clavicle, and it's also the collarbone, is a slender S-shaped bone attached by ligaments to sternum and one end of the acrum process to the other. Sorry, I got confused there for a second. Because of the clavicle, the slender and very exposed, the bone is vulnerable to injury. So I've seen these broken a couple of times. The clavicle, I've taken care of 2 of these. They're painful, but if you stabilize the patient's arm, like across their chest, they don't have near as much pain. I've never dealt with a scapula injury, so those are pretty serious. Now you can also mess with these little joints up in here and these bone fragments when it's connected to your sternum. I hear those are mighty painful. A humerus break is really rough, and here parts of your clavicle is painful in itself, as long as it's not moving around. So here's the The upper extremity extends from the shoulder to the fingertips and is composed of the upper arm, which is the humerus, and the radius and ulna. Joins to the shoulder girdle and the glenohumeral joint. The humerus connects to the bones of the forearm to form the hinged elbow. So right in here, this is where we're going to come in here to our hinged elbow. This is going to be the ball and socket. That's where it was talking about connecting into the scapula. And there's also another ball and socket joint that we'll talk about in a minute, and that'll be the only 2 balls and sockets that we have. So we have here where the elbow joint is here, your radius and ulna, and your humerus. I would try your best to learn these, your tib fib, all of those, and your femur. Those are very important, and you need to know which ones those are. All right, so in your hand, you have wrist bones, which is your carpals. Your hands, you have metacarpals, and your finger bones are called your phalanges. Your toes are kind of the same way. You have little phalanges down there. So here's broken down. Your wrist is your carpals. It comes in more into your hand with the metacarpals, and then from knuckle area down, that's all considered phalanges. And if you didn't know, these are your 1, 2, 3, 4, 5 fingers. All right. So the pelvis supports the body weight and protects the structures within the pelvis, the bladder, the rectum, the female reproductive organs. The pelvic girdle is the 3 separate bones, which is the ischium, the ilium, and the pubis. They all fuse together to form the hip bone. And here is broken down from the leg. So the lower extremity consists of bones of the thigh, the leg, and the foot. You have your femur, which is right in here, which is your thigh bone. That is the longest and the most powerful bone that connects the ball and socket. As you can see, this is the other ball and socket I was referring to. And the lower leg consists of two. Here's your fibula and your tibula. These are very important to know. Learn this along with your arms, and at least you know if you go to a skill session and they're like, they have a right broken tib fib and it is protruding the skin, and you're not up here on the arm trying to figure out where the tib fib is. So make sure you know those. Here's your toes again. We talked about your phalanges. You have your tarsal. You have your metatarsals in here, and then your phalanges again. Here's your tarsal up in here. Now, we've seen this a lot. My son's actually dealing with this. He overstretched the tendon that attaches from the tibia down into the I forgot what bone that is. I know it's not the ankle bone itself, but they'll overstretch that, and you'll see that a lot. Just words of wisdom here. I'm teaching you something else on the side. People that walk up and down stairs a lot will actually have issues with that tendon, and they'll stretch it, and it'll be very tender. And also people that lay floor. So if you think about, they're on their knees a lot, and their feet are in the flat position, that overextends that tendon, and that's when they have issues there too. Sorry, it's just a side note, but I'll teach you something else. The bones of the skeleton provide a framework to which the muscles and tendons are attached. So a joint is formed wherever two bones come into contact. So if their tib fibs come together and your humerus, all those are particular joints. Joints are held together through a thorough fibrous structure known as a capsule, which is supported and strengthened in certain key areas by bands of fibrous tissues called ligaments. In moving joints, the end of the bones are covered with a thin layer of cartilage known as the anterior cartilage. So right in here, you'll have your cartilage built into here. That is your padding, basically your shock absorber. You can overwork and get rid of all your cartilage in certain areas. So the joints are bathed and lubricated in the synovial fluid. That's the lubricating fluid that we were talking about here. That's in our joints. Joints allow a circular motion like your shoulder. Your hinge motion is your knee and your elbow, and that is minimum motion. Your arm can go in 360s. Your legs can only go in two directions, forwards and backwards. Your sacrum and your sternoclavial joints is your, and then of no motion structures in the skull. So the skull's not going nowhere. It's going to stay in place. We're not doing anything with it there. So the musculoskeletal injuries, we want to know the mechanism of injury because this helps us determine what type of injury that we're expecting to see. Do we have direct blows, indirect forces, a twisting force, high energy forces, as in car versus pedestrian? A significant MOI is not always necessary for a fractured bone. A slight force can easily fracture bone that is weakened by a tumor, infection, or osteoporosis. Suspect the presence of a fracture in any elderly patient who reports pain and has stated a mild injury. Anytime that you suspect that an elderly patient has slipped, tripped, and fall, automatically assume that their hips until otherwise are injured. You know, that is a big spot that we have issues with. Those is anytime that they fall, they will have hip injuries. So, and they'll complain of it, but at the same time as we have to do a good enough assessment, and a telltale sign, it'll talk about it later on in here, is pain to the site, swelling, and rotation of one foot versus the other. All right, so fractures. A break in the continuity of the bone often occurs as a result of external force. So something from outside the body has caused a large enough force to create a break. So this classified as either open or closed. We've talked about that in some other chapters. So just real quick, when an open fracture, there is an external wound caused either by the same blow that fractured the bone or broken bone ends lacerating the skin. Ooh, I don't like that idea. You should treat any injury that breaks the skin as a possible open fracture. Complications of open fractures include increased blood loss and a higher likelihood of infections because we've ruptured the skin. We're allowing things from the outside area to enter the body, which is not what we want to do. Fractures are also described by whether the bone is moved or from its original position. A non-displaced fracture, also known as a hairline fracture, is a simple crack of the bone that may be difficult to distinguish from a sprain or simple contusion. A displaced fracture produces an actual deformity or distortion of the limb by shortening, rotating, and angulating. So here's what we want to talk about. So this is your green stick fracture. It will most likely twist. It won't break. It's like taking a green limb off of a tree and twisting it and try to break it. It doesn't really want to. It only will twist and turn and break the outside, and that's really that. So B right here is the oblique fracture. It takes from one side, it's an angular fracture. Now this one right here is going to be very, very painful. That's the pathologic fracture. And then this one is an incomplete fracture. I don't know where that. I guess we're not going to see it since it's incomplete. Maybe it's up here at the head. I don't know. We'll say right in that area. We'll guess. It's our story. We'll stick to it. All right. So communicated, a fracture is in which the bone is broken into two fragments. Epiphyseally is a fracture that occurs in a growth section of a child's bone and may lead to growth abnormalities. So a green stick is an incomplete fracture that passes only partway through the shaft of the bone. These are also Broke's, the second one that I obviously have trouble pronouncing. That right there is also known as a growth plate fracture. Sometimes if it's in a fracture in a growth plate, they will spend a lot of time in a cast. They may not do surgery initially because of where its location is, but they have to be very cautious of where it is, what it is, and why is it like its status, because if it's not fixed, that particular limb may be deformed as it goes through the growth process. An incomplete fracture is a fracture that does not run through the bone. Oblique is a fracture in which the bone is broken at an angle across the bone. And a pathologic is a fracture of a weakened or diseased bone generally produced by minimal force. A spiral is a fracture caused by a twisting force, causing the oblique fracture around the bone and through the bone. A transverse is a fracture that occurs across the bone. Ooh, those just sound super painful. All right, so here comes our glory, wonderful pictures. All right, suspect a fracture if one or more following signs are present. You have deformities, tenderness, guarding, and swelling. Pretty sure that's obvious. That's not supposed to be like that. I bet you that's either from a soccer injury. Maybe if you look into here, I would just go with the soccer, but I don't think his legs should look that bad. Here we'll look on the patient's right side. This, I would say this is normal, because if you look right in here, you see all the swelling that you don't see in here. So the left leg is going to be normal here, and then the right leg is where you're going to see your swelling. All right, if you look, whoa, where's this at? So if you look here on the foot, we've all had these. These are signs of fractures. May also be severe strains and sprains. See how you start to see the pooling of the blood here? And now through days, you may get these to be super black in color. You may see them purple. They look like, you're like, oh my God, that looks really bad. And that may be a couple of days down the road. Now, when you start to see feel crepitus, is when you're holding the ankle and they move it at all and you feel the bones rubbing together. That's gross, y'all, I promise you. False motion is when they're not moving it and the leg or the ankle right here in itself goes without them making it. Exposed fragments, we know, pain, and then the lock joint to where they have no control, they can't move it, twist it, do anything with it. So dislocations is a disruption of the joint in which the bone ends are no longer in contact. The supporting ligaments are often torn. They're usually completely allowing the bone ends to separate completely from each other. A fracture dislocation is a combination injury at the joint in which the joint is dislocated and there is a fracture of the end of one or more bones. Sometimes a dislocated joint will spontaneously reduce or return to its normal position before your assessment. Now, you may see that also in shoulders. I know a lot of people will see those in shoulders and just think everything's fine, but people will be able to pop their shoulders back in there together. Stand by a second. Let me. All right. So you'll be able to continue confirm the dislocation only by taking a patient's history. A dislocation that does not spontaneously reduce is a serious problem. So if it doesn't try to go back in the same way that it came out, it's going to have to be reduced at a facility. And its commonly dislocated joints include fingers, shoulders, elbows, and a knee. Obviously, shoulders are way more than I see the rest of them. Signs and symptoms of dislocated joints are similar to those of fractures. So they have the marked deformity. They look weird, and you're like, nah, I don't know. That just has your fingers always been sideways. You know, you see those injuries in football, getting caught between things. Tenderness on palpation. You'll have your virtual complete loss of normal joint motion, so the joint is locked, and the numbness or impaired circulation to the limb or joint. So you start to have, stand by, there's a picture, we'll go over that in a minute. So when we talk about sprains, a sprain occurs when a joint is twisted or stretched beyond the normal range. The supporting capsule and ligaments are stretched or torn. Sprains can range from mild to severe. The most vulnerable joints are the knees, shoulders, and ankles. After the injury, the alignment generally returns to a fairly normal position. Those are some of the things that you may still have to be seen by they may put you in a soft cast. They may put you like in one of those little walking boots to try to help relieve some of the pressure in certain places. But you can limp back with a sprain. We start talking about, you know, like this crutches and stuff like that will help you move forward. Here's a good picture. And so signs and symptoms of this one. She's going to be guarding swelling, and you'll have ecchymosis, you'll have pain and instability in the joint. So this right here is going to be super painful. This right here is just pooling of the blood, which is going to have your ecchymosis right in here. She's going to have more pain in this area than down here at the bottom of her foot. That may be swollen because of the blood and the inflammation in there, but majority of your pain is going to come from right in this area right here. The heel may just be irritated because of the location of the swell or the sprain. So you can move forward from there. And also know that in EMS, we are not sports medicines. So we don't know how to properly wrap ankles, put them in, you know, wrapping positions. If you've been through those courses, man, amazing. I think it's awesome. I wish I knew more about supporting, you know, wraps and stuff like that. I really wish I had that experience just for personal reasons. But all we can really do sometimes is just elevate it and put an ice pack on there and help transport them to the facility. And depending upon your service and your level of care, you may be able to do pain management at the same time. So a strain is a pulled muscle that's stretching from tearing of the muscle, causing pain, swelling, and bruising of the soft tissues of the area. You'll hang on. All right, so unlike a sprain, no ligaments or joints are damaged typically. Now, these are, if I had to take one, I really wanted to get a strain versus a sprain. So that's just personal. Most patients will have extreme pinpoint tenderness. Well, sorry. So in here, like when we're looking at this picture, she's gonna have more like it hurts right here. It doesn't hurt anywhere else, but this is where it hurts. If you touch right there, I'm going to kick you. Those are kind of the assessments that you get from those. All right. So when we talk about amputations, I personally believe that amputations are the easiest to take care of because it's a tourniquet. Get the amputated piece and transport it with you to the facility. Now, you still have patient care and your assessments and all that, but ultimately it's semi-easy once you put that tourniquet on and you bandage it and you cover the amputation part. Well, so this injury can damage every aspect of the musculoskeletal system, from bones, ligaments, to muscles, to nerves, to tendons, to all that fun stuff. An amputation is an injury in which the extremity is completely severed from the body. You can have partial amputations to where it's still hanging, and it may be hanging by skin or tendons, but that's considered a partial amputation. So here, the complications you're going to have is all orthopedic. Those are going to be a traumatic patient for us no matter what. So we're going to do a rapid assessment for them, and they're going to be a rapid transport. We're not going to stay in place. Orthopedic injuries can lead to numerous complications, not just those involving the skeletal system, but also a systematic changes for illness. The likelihood of having a complication is often related to the strength of the force that is caused by the injury. You have your injury location and your patient's overall health. So if they're in general good health, they're not going to have as much trouble as somebody that is complete out of shape, overweight, that they're going to help recuperate better. Their body's going to be more adjusted to things and move forward from there. So that's the reason why the patient's overall health is important, because we still want to make sure that what we're doing is good and what we've done is good, and we don't want to cause any harm. All right, to prevent contamination from following an open fracture, if you can, brush it away. Now, I'm not saying get the brush out of the side of the truck that you clean the dirt out the truck for, but if you can, take a sterile dressing and try to remove any types of dirt, grit. If you need to, you can pour saline on there, some saline water, sterile saline water, flush the area. Do not poke or probe inside the fracture. That's not our job. We don't have enough medication sometimes to medicate these patients. And then now you're doing something that really shouldn't be done by us. So if you see it, make sure you take a note of it and be like, hey, there's a rock right there. I'm not digging my fingers in there to get it. What we really want to do here is reduce the risk of wound infection by cleaning it and transport the patients to the appropriate medical facility. You can help reduce the risk of duration of long-term disability by preventing further injury, which that's our overall goal for taking care of any patient that we come across, is preventing further injuries. Reduce the risk of wound infections. Transport your patients to the appropriate medical facilities. It depends on what your local protocols say. They may tell you you have to take a certain type of injury to the closest facility, but knowing that it warrants a trauma center. Again, you need to make sure that you know what your policies and procedures state. Stay by real quick. I got to mute and blow my. All right. Now I can't hear anything. Sickness has moved in behind my ear and I'm struggling. All right. So we're going to talk about the golden hour. So you may hear it referred to as the golden period, the golden hour. I know it as a golden hour, so that's what we're going to refer to. So the golden hour is critical, and not only for life, but also for preserving limbs viability. So in an extremity with anything less than a complete circulation, prolonged hyperfusion can cause significant damage. So if we know that we have this wound and we put a tourniquet on there and we're basically creating compartment syndrome, it can cause death of that situation, of that limb later down the road, or they can potentially lose it over altogether. So with that being said, is make sure when you apply that tourniquet that you rapidly transport your patients to the facility, and that you note exactly what time that wound, that tourniquet was put on. They have the places where you write on there for reasons. Most services in the area that I've directly dealt with are going towards the full cat orange tourniquets. And the reason why they're doing those is they're more visible versus the black tactical ones. So, and that's an important issue, that when you put a tourniquet on, make sure you relay that information to the facility, and so they know that there's a tourniquet been applied. Don't cover it up. So on patient assessment, always look at the big picture, y'all. Evaluating overall complexity of the situation to determine any life threats, because I want to know initially, is this a life threat, or is it something that it's a filler? Is this filling my attention until I can see something else? Note that injury and move on. Once you've assessed it and you've done a full head to toe assessment, you can come back and treat that later. Now, if it requires you to control the bleeding, stop the bleeding, anything to do with circulate, ABCs, airway, breathing, circulation. If those are your most important things, if you're going from the head to the toes and you make it to the arms and you realize, oh, I've got a arterial bleed, you need to fix that and fix it right then. Then once you can do is you can move on. You're not forgetting to do the rest of the body. You're just trying to manage your patient's likelihood to survive. I need you to be able to distinguish between mild injuries and severe injuries, because some of these injuries may comprise of neurovascular functions, and that's going to potentially threaten long-term function. So if we don't catch it in enough time, when we probably should have been paying attention, that we could potentially cause longer harm. Now, and if that's the case, they're going to come after you. They're going to come after everybody in the medical facility, and it depends on exactly what your notes are on your report, is if it's going to be your fault or is it going to be the medical facility's fault, because they're going to sue for everything. Seeing size up, it's the same size up as everybody, y'all. Look for your MOIs. I'm not going to go over that. Well, ABCs, we know that. Check for responsiveness using our AFPU. If you're able to ask what their chief complaint is. If there's a significant trauma and multiple body systems affected, the musculoskeletal injuries may be a lower priority, because it's okay for them to have that open bib if it's controlled. If it's not oozing, goozing blood, leave it alone. We'll come back to that later. We can fix that on the secondary assessment. Fractures and sprains do not create airway and breathing problems, so we're not really worried about that. We want to make sure that we continue, see what our chief complaint is, what's the MOI, move from there, and let's rapidly take care of this patient. We talk about circulation. Again, y'all, head to toe, put your hands on this patient and make sure that you assess the skin for the pale, cool, clammy, the cap refill, and start looking for signs of shock. The way you're going to do that is you're going to also check their vitals. You're going to have a vital assessment so you know exactly where they're standing. And if you start to see deterioration, that's going to be your telltale sign as your vital signs. Transportation decisions, y'all, this is a personal thing. I can pound and pound and pound and tell y'all, these need to go, these need to go. But again, you're the patient's care provider. If that's something you're like, I'm okay, I'm comfortable with this, I don't need to go lights and sirens. That's you. You're the one that has to make that decision. But if they have life-threatening decisions, load and go, don't stick around. Histories, if we can obtain a history from somebody, from the patient, that's fine. We can obtain it as we're going down the road to the facility if it's a traumatic event. If not, if we can't, if the patient's unresponsive, you can quickly say, hey, does anybody know anything about this patient? What? Okay, no. Well, what did y'all see last? I saw him tumbling down the interstate once the car come to a rest after it was been rolled over. So those are the things that you have to look for, and knowing the questions to ask, who to ask, when to ask, and basically how to ask those questions. Secondary assessment, that's going to be as we're going down the road. Don't do these in a traumatic event as you stay at the stay on scene. Do these as you're trying to take this patient closer to the facility. So once you get closer to the hospital, that's when you can start working on these assessments, the secondary assessment, and that's when you're going to be, hey, I need to go back over this. Did I find any other injuries to their upper extremities? What about the lower extremities? So, and then you can note several abrasions found to left forearm. Bleeding was controlled on during secondary assessment. All right, so when lacerations are present in an extremity, an open fracture must be considered. Talk about your bleeding control, apply your dressings. If you need to apply the dressings, then fine, that's, control that bleeding. But if it's not a life-threatening bleed, stop it and fix it in your secondary assessment. Attain a baseline neurovascular, or do they know where they're at, what's going on, who they are, what time of day, what time of year is it, time, date, year, and who the president should be. Everybody knows those questions. So that's something we want to ask, very simple questions. Don't ask the one like, hey, who's this lady right over here? And this lady's like, I don't know this man. And the guy's like, I don't know. That you can't evaluate somebody's neuro on them not knowing just because you're like, oh, well, I thought y'all together. No. Examination of the injured limb. Here's our 6 P's. Remember those: pain, paralysis, paresthesis, and that's numbing or tingling, pulselessness, pallor, and pressure. Again, what's our baseline vitals? We're going to be checking these pretty rapidly, pretty aggressively too, so we know exactly where we stand on our shock. If they're in shock, are they getting close? Or do they have hemostasis? Are they maintaining their own on their own? What do we need to do for them? Repeat the primary assessment. Ensure your interventions are working. Double check that tourniquet. If the tourniquet's been put in place and it's working, hold it, use it. Always go back and double check them. If you notice that there's more bleeding coming from it, you can turn it. You crank it down one more time. You can always apply another one. That's okay. You do high and tight. Assess the patient's overall condition, stabilize the ABCs, and control any serious bleeding. In critically injured patients, you should secure the patient to a long backboard using a C-spine. You want to make sure that you tie start with their pelvis, do the abdominal area like their chest cavity, and then go to the legs. There's certain ways that we want to secure the patients to the backboard so we know that they are secured and they're not going to fall off. Let's see here. In this situation, a secondary assessment is a waste of valuable time. Reassess the patient en route to the emergency department. Always do these secondary assessments on the way to the hospital. I want to make sure that y'all get that. These assessments should be done on the way to the hospital. If the patient has no life-threatening injuries, you may take a little extra time. Be like, what's up, bro? Tell me what's going on. Do you remember when you were thrown off your bike and hit that tree? And they say, yeah. And you're like, oh, God. All right. Well, what do you remember? What's the last thing you remember? And they tell you everything. They may not have lost consciousness. So maybe a good thing. After assessing the extremity, apply a secondary splint, commercial or otherwise, to stabilize an injury prior to transport. It's okay. It is very hard to apply a traction splint, air splint, cardboard splint as you're bouncing up and down the road. I can tell y'all, take that extra time before you go to stabilize those injuries. Put those traction devices, the air splints and the cardboard splints, put them on prior to leaving, because it will just be, it'll benefit you and behoove you in your patient care as you're going down the road. Um, Communication and documentation. If you did it and you don't write it, you didn't do it. If you didn't do it and you wrote it and they found out, you're going to be guilty for everything from that point forward. Document the presence and abscess of circulation, motor function, distal sensation, injuries prior to moving an extremity, or manipulation or splinting of an injury. So when they say about moving them or manipulating, remember, if you touch a limb, let's say the leg, and there's no pulse, you have one time to angulate that leg at the right, to get it in its natural position, to obtain a pulse. If it's too mangled and it just does not look right, or you don't want to do that. But if you happen to uh, see that, and you can manage it and slowly put it back in its natural position, and you obtain a pulse, you have to document what you did, how you did, and how you stabilized it, because that is something you did that benefited the patient. And then throughout the transportation of to the hospital, you're like, hey, I reevaluated this area, still have a good pulse into the limb, because that's important. You made a really good move then. Hey guys, I'll tell you what, let's take a quick little break. I need to go take care of something. I'll see y'all back in 10 minutes. Let's do 6:52. I'll see y'all back in 10 minutes. So give me just a little bit. All right, guys, sorry about that. All right, so here in splinting, so basically what they're going to give you the definition of a splint is a flexible, rigid device that protects and maintains the position of the injured extremity. Now, again, it doesn't have to be a one that you buy from the store. It doesn't have to be anything like that. Trying to answer messages, sorry. Unless the patient is in immediate danger, you should splint all fractures, dislocations, and sprains before moving the patient. So it's a life over limb. If you have to move them in an emergency situation to save their life, you just grab and pull and go. But if not, and you have time to sit there and stay and play, make sure you get all your splints, you get everything situated, your tape, cut it the way that it needs to be, specifically on like cardboard splints. Um, I like cardboard splints a whole lot better than air splints because you didn't got to worry about getting them back. Air splints are a little bit more expensive. They do work really well, but I'm an old school kind of guy. So once you splint it, it does help reduce the pain, and it makes it easier to transfer the patient from from the ground to the stretcher to the hospital bed. So all those will. That's why we want to move it the best and splint it, because you got to think, if you have an uneasy ankle and you're moving them and jerking them and flopping, and there's nobody supporting that ankle, that's going to be super painful. That's going to hurt a lot. Um, so splinting that up front is where our benefit is, and that's why we want to do that. So splinting will help prevent some of the following here. So you're going to prevent further damage to the muscles. So you're going to keep the bone ends from scratching and tearing the muscles, the spinal cord, peripheral nerves, and blood vessels from broken bones. You have laceration of the skin by the broken bone, reductions of distal blood flow, restriction of distal blood flow resulting from pressure of the bone ends on the blood vessels, excessive bleeding on the tissues in the injury site caused by broken bones, increased pain from movement of the bone ends, and paralysis of the extremity. So your general principles of splinting. So remove clothing from the area and suspected fracture of dislocation so that you can inspect the extremity for decap BTLS. Now, if you can, it's okay to cut shoelaces, that's fine, but be cautious when you go to cut like leather boots, work boots. Make sure the patient knows what you're doing. Don't just specifically bikers. Be very, very cautious cutting their leather. Let them make that decision. I've taken care of several hardcore bikers that had some major injuries, and they said, whatever you have to do not cut my leather. I'd rather you move me around and cause more pain. Okay, so I respected that. So know and record the patient's neurovascular status. Basically, I want to know, do they have pulse motor sensory to there? What's the PMS? Cover an open wound with a dry sterile dressing before you splint it. It keeps from any type of debris coming in there. Do not move the patient before splinting an extremity unless there is an immediate danger to the patient or unless there are threats defined in the primary assessment of the ABCDs that you're unable to correct. If the suspected fracture of the shaft of a bone, be sure to stabilize joints above the elbow, joints above the elbow. Let me read that again. I just messed that all up. Be sure to stabilize the joints above and below the fracture. Whew. Okay, so if it's in the elbow, we want to make sure we secure the whole arm. We want to go above and below. We want to make sure that we tape it at the top part of the arm, the lower part of the arm, and that we can see the area of dislocation, break, because at the same time as we need to monitor that area for swelling. Is it cutting off any blood loss? We may or may not have a pulse in the area depending upon what's going on, the type of injury. If you don't have a pulse, make sure that's noted and what time that you found that injury to be there. If it's with injuries in and around the joint, be sure to stabilize the bones above and below the joint. Also, because you want to make sure that you keep those joints secure and you don't want them to freely move. Pad all rigid splints to prevent local pressure and discomfort of the patient. So you want to pad all your void places. Apply the splint, maintaining manual stabilization and minimize the movement of the limb to support the injury site. If a fracture of a long bone shaft has resulted in a severe deformity, use constant, gentle manual traction to align the limb so that it can be splinted. Now, you may have to do manual traction where you grab the wrist and you pull, and it gives just enough pressure to off of it until you're able to stabilize it correctly. Immobilize all suspected spinal injuries. Make sure they stay in the neutral inline position. If the patient has signs of shock, align the limb in the normal anatomic position and provide transport. When in doubt, always splint. If you think that there's a potential issue, we don't have x-ray out there. It is dark. It is on the side of the road. You're upside down in the car. You just splint and just be like, hey, this is what I think. I don't know. I can't tell. So rigid splints, they are not really formable. Some of these splints are made from materials that are applied to the side, front, and back. If you'll look in your book on 32.2, it shows you there. These do take more than one provider to put these on. They can be time consuming, so think about that. You may note metal in these. We used to, back in the day, used to have a ladder splint that would be, it looked just like a metal ladder. I called it lattice on the side of a house, but it was super small. You could use them on arms and legs. You couldn't use them on anything else, like wrists and stuff like that. Those are really hard. A lot of your services now use SAM splints. SAM splints are amazing. You can get them all the way down to finger size, all the way up to taking care of a femur fracture. So SAM splints come in different sizes. The good thing about SAM splints too is if you don't need it, you can cut it. They do have a metal board in there, and that metal board allows them to x-ray that too. A lot of places don't want to do that. So once you get there, drop them off and all that, they will sedate them and remove that metal board. And that's okay. That's not on us. We did what we had to do, and we got them there in the best way that we could. So let's see here. In 2000, spent the limb for me. Okay, we'll skip that one. Formable splints. These are considered your air splints, your pellet splints, sling and swath. That is a testable skill, is the sling and swath. There is a slideshow in here, I think, on the sling and swath. If you will look on 32.3 in your book, it talks about how to apply the vacuum splint. I don't have one of those here. I don't have any of that at my house to show you how to do those. So a pillow splint, y'all, is just like taking a pillow, something soft, and magazine splinting them also. Boy Scouts, Girl Scouts, you've all kind of, everybody has an idea of how to, form a splint. We're all, grown adults at the same time. We can figure something out. 2 sticks would work too, instead of just letting them carry it, flopping around, hanging out and hurting, causing more pain. Pelvic binders. So a lot of services don't carry pelvic binders because they are super expensive. And the bad thing is when you use it, you don't get it back. It goes to the facility, and then you got to track that down for for days. If you're lucky, you get it back. If not, you just lost out on that. They're super great. They help pad and split the pelvic area, but a lot of times I just like using a sheet. I'll take the top sheet, fold it in half a couple of times to where it's about 8 to 10 inches wide. I'll slide it underneath the patient, and then I will take, once I've palpated the pelvic. Now again, there's another slide in here on how to palpate the pelvic, and I'll go over that. But the sheet is really cool on trying to secure that injury. So the sheet method is awesome. So if somebody can show you that, it's just like putting the sheet underneath them and tying them in a big bow. You want to try to get it as tight as you can. Sometimes you can't get the sheets tied. It's okay to twist, twist, and twist, and tape it. And you will use a lot of tape. Hazards in improper splinting, we know if you don't do it right, it's going to cause harm. It's going to aggravate that injury more. It potentially can cause more damage to that area because it's not secured properly. You may lose a pulse if it's not done correctly. You may note swelling to the area, more redness because you didn't apply it correctly, or there was a better way to do it and you just didn't get done. And it may be to time and location. And very few, if any, musculoskeletal justify the use of excessive speed. We don't want to, transport in a lights and sirens mode all the time. That puts us and the general public for a risk of injury, and we don't want to do that. We want to make sure that we cause no harm, no do harm to anybody else around us or on the way to the facility. But be cautious. If they don't, it says on y'all's right there, number 2, it says if a patient with a pulseless limb must be given a higher priority. So they may warrant you going lights and sirens, but if they just have a broken femur, that's not lights and sirens facility. Unless there's something else that's secondary to that, signs of shock, you note a blood pressure change to where that their blood pressure is bottoming out. They may be pulling blood into their thigh area, and it may be something that you're like, this is life or death, and I think we need to get there fast. That may warrant it then. So clavicles and scapulas, we'll show you. I'm just going to show you this right here. So this is a sling and swath. Those are most of the ones that you're going to want to do for the clavicle and scapula area, because what it does is it supports the arm with the body, and then you use one to go up and around the neck. You'll create a little hole right here, and then you'll do one around the body too, because what that does is it keeps it from any side motions, and it secures it more to the body. Tying it right up in here is going to be difficult because we have larger people in America, and sometimes these sling and swaths were not adapted to that. So tying these knots may be more down into, where's my mouth? I don't know. But it may be more to like way back here versus down here on the side of the neck. So we have issues when we go to splint and tie the sling and swaths because of that. Those weren't made any bigger. So dislocations of the shoulder. The shoulder joint is where the head of the humerus meets the phenoid fossa and the scapula. The humeral head most commonly dislocates anteriorly, coming to lie in front of the scapula. So it's going to be in the back. As a result of forced abduction and external rotation of the arm, you'll see a picture in a second of a elbow injury that's rule. Some patients may report numbness to the hands because either nerve or circulatory compromise. You may have a pinching of a nerve in that area, or there just may be the location has compromised the blood vessel. Stabilizing an anterior shoulder location is difficult because any attempt to bring the arm toward the chest wall produces a lot of pain. Whew. You must splint the joint whatever position is most comfortable for the patient. Apply the sling and forearm and the wrist to support the weight of the arm. Secure the arm to the sling and the pillow and the chest to the swath. So fractured humors, man, I'm just gonna tell you, they're not comfortable either. You're just gonna want to put the patient in the most position of comfort that they will allow. If they say this is where it's comfortable, don't touch my arm, don't mess with my arm because they've already manipulated it, moved it around. Just leave it. There's really no reason for us to mess with it besides just to secure it where it's at. So elbow fractures are nasty. They just look real gross. Fractures and dislocations often occur around the elbow, and the different types of the injuries are difficult to distinguish without x-rays. They all produce a similar limb deformities and require the same emergency care. Fractures of the distal humerus. This is the type of fracture also known as a subcondylar or inner. I do not know how to pronounce this. These are common in children. Frequently, the fractured fragments rotate significantly, producing a deformity, causing injuries to nearby vessels. So here you go. That's what they look like. I'm just going to say that does not look comfortable, and neither does he. He does not think that that's in the most comfortable place, and that probably was not a good tumble for him. There is going to be swelling, and there's going to be potential for vessels and nerve injuries in there. The posterior displacement makes the ornamental process of the ulna much more prominent. These are issues that we're going to have. They're going to be in a lot of pain. You're going to need to medicate this patient, and this is a ALS majority call. You're going to need to medicate this patient prior to moving and trying to stabilize the joint. You're going to have to put some drugs on board. This can result from a direct or indirect force and is often associated with lacerations and abrasions. The patient will be unable to actively extend the elbow. Duh, it's messed up. These are often missed, but it's not something we see common, so it's we can get passive in that. This generally occurs in a result of a fall of an outstretched arm or a direct blow to the lateral aspect of the elbow. Attempts to rotate the elbow or wrist cause much discomfort. An elbow injury are potentially serious and require further or careful management. The reason why is you need to assess the distal neurovascular functions. You want to do PMS. If you find a good strong pulse and a capillary refill, splint the elbow injury in the position in which you find it. Mark on the wrist with a Sharpie of where you found their pulse at. That is very good because when they come back later on, they get in the facility and they're like, well, where did you find it? Well, I found this pulse right here. Well, it's no longer there. Well, I can just tell you that's where I found it. So a cold, pale hand or a weak or absent pulse is a poor circulation, and that is indicate as the blood vessels may have likely been injured. If the limb is pulseless and significantly deformed at the elbow, apply general manual traction in line and the long of the axis to decrease the deformity. If you're not comfortable doing that, just don't do it. Provide prompt transport for all patients with impaired distal circulations. Fractures of the forearm. These are most seen during children. Usually both breaks at the same time when the injury is a result of an outstretched hand. Fractures of the distal radius, which are especially common in elderly patients. You have osteoporosis, also known as Achilles fractures. To stabilize these fractures of the forearm or the wrist, you can use a padded board, which is a cardboard splint, an air splint, or a pillow splint. Wrist and hands, man, I'm gonna tell y'all these just depend on the way that the patient is. There's a skill show y'all on 32.4 that gives you ideas on how to splint, but at the same time as I could show you 50 different splints and you would learn a 51st different way as soon as you got out in the field. It's generally what we want to do is the position of comfort and to maintain a pulse. If we have good pulse and PMS, we want to splint it in that position. So here we start talking about fractures of the pelvis. These do result in a heavy blow or laterally crushes the pelvis. Now, this may be from a slip, trip, or fall. I've seen a very good pelvic break from a lateral MVC collision. The young girl was struck on the driver's side of the vehicle, and he intruded on the car about 2 foot, which caused her to meet the side of the car to her hip. It did fracture it and broke it on both sides. She was in pretty bad shape. But other than that, she was talking, she was screaming, she was hollering, but she could answer all your questions. We had to medicate her before we could move her at all. Most of the time, open fractures to the pelvic are going to be very uncommon. Pelvic fractures can lacerate the rectum, vagina, and the bladder. So what you potentially can have is dumping of all those into the pleural space. So if you think that it's something severe, do a rapid assessment. Is it firm? Is it soft? Is it distended? Check that area so you know initially what you're looking for. And then when you go back down the road later on, if there's changes, you already have a baseline of what you're looking for in their pelvic. Suspect a fracture to the pelvis in any patient who has sustained a high velocity injury and complains of discomfort to the lower back or abdomen. There's a picture on the next one that will kind of show you how to palpate the pelvis. We talked about the deformity, the swelling, the tenderness, pain to the area. If you have it, it's easier to use a scoop stretcher because what it does is that you don't have to log roll the patient to one side or the other to put them on a backboard. You can use that scoop stretcher, but be cautious on those scoop stretchers. When you go to pinch it or close it, what happens is they can pinch, and once whatever's in there, sometimes it can pull it too. Hair is a big thing that gets caught up in there. Most people like to take them completely apart instead of using it in like a V. So just some experience there. So here, what we want to do is now, what we have to be careful of is when we palpate the hips. When you pushing in on both, you're pushing against this iliac crest right here. So you're checking this area for stability and this right here. So when you go to push down on the top of the pelvic, you're checking the stability of this pubic stiffness. Now, they don't like you to do these because what you can do is if there's any type of major deformity in these bones and this area are broken, or we saw in here earlier that these are broken, you can actually create more damage by doing a pelvic assessment. They tell you to mainly palpate the area, do a quick assessment. I only like to do this one. That can tell me a lot because pushing down on either side versus this one, I will not do that one. And that's checking the stability of the pelvic itself on either side. So pushing in and pushing down will give you enough information. But the number one, I'm telling you, the telltale sign is that shortened and rotated foot. When you look at them, now ask them, hey, are your feet normally that way? Do you walk with a limp? No. Well, another way you can tell is if you go to move them, they're like, oh my God, my hip hurts. Well, guess what? Now we know your hip's broke. Yes, the patients will hit you back. Sometimes they nice, but sometimes they don't care who you are, and they try to tell you, don't touch me there, it hurts. And then when you do it, you may get hit, and that may be from your own injury. So just the dislocations, that is a significant injury. The hip is a very stable ball and socket joint, and it dislocates only after significant injuries. So if you notice that there is a hip displacement or an altered location, it probably means they got hit pretty hard or they slipped, tripped, and fell. That is a direct force that has caused them to land on their knees, their buttocks, their hip, and has broken the area. Dislocation of the hip is associated with a very distinctive sign. You do have severe pain, resistance to movement, tenderness on palpation, and the ability to palpate the femoral head. Some patients you can feel that femoral head. Some of them you may not be able to because they may be from the south and they may be thicker than the other ones. You can feel them pretty much if anybody has their own child. I mangled and palpated, and I learned all about pediatrics when I was going through paramedic school because I put my child through the ringer. I was like, oh, I wonder if I can feel this, and then I would, rotate his leg out in a way, and then you could feel the head of the pelvic, and it was like, whoa, that's pretty cool. So just know that those ball and socket joints can be palpated in certain areas. As with any other extremity injury, do not attempt to reduce the dislocation in the hip in the field unless medical control directs you to, because there may be a underlying issue due to distance of transfer, unable to fly. There may be some reasons, but that's a medical control call only. Splint the dislocation into position of deformity and place the patient on a spine board. I still question that because it's not going to be comfortable for them to be on a backboard. It may just be easier for you to put them on the stretcher and pad all their voids. If you can put pillows, towels, and those blankets in those areas underneath their knees, to keep their knees at an angled position. That may be just what's the most comfortable for them. Support the affected limb with pillows, roll blankets. We already said that, so I guess I skipped off there. Fractures to the proximal end of the femur are common fractures, especially in elderly people. We know that comes with osteoporosis. Patients display a very characteristic deformity. They lie with the leg externally rotated, and the injury limb is usually shorter. Oh, I was right. I told y'all. Patients typically are unable to walk or move that leg without severe pain. They're not going to be able to amputate, so they just can't move. You're going to have to do it all for them. The hip region is usually tender on palpation, and a gentle rolling of the leg will cause pain. But do remember, when you're doing your assessment and you decide to put them on a backboard because you just need to move them, you're going to remove them off of it. Don't roll them to that side of the affected area. Roll them to the opposite side. So if my right side is broken, I'm going to roll them to my left side. Click. Yeah, we talked about that there. Let's see here. Traction splints. They're primary secure fractures. And now, when you go to use a traction splint, I don't remember exactly where in your book has pictures of the traction splint. I know you should have used them in your boot camps. But the only bad thing about these traction splints is they're long. They're not going to stick out the backside of the ambulance. But if you have a guy that's about anything taller than 6'6", or depends on where your stretcher sits in your ambulance, you have to be very cautious. If you use the traction splint and shutting the door, you can potentially hit this traction splint. So be very cautious of that when you go to use them. They do take a little getting used to. They take a little prep setting them up, but once you get that traction splint working and you get everything in the right spot, it is a different person. When you put that on there and you start pulling traction, and literally they're just like, oh, that's amazing. So know that that's just one of your signs to where if you know that you've got it. How do you know when is when? Well, trust me, they will tell you that feels great. Don't use for any other extremities. Injuries close involving the knee, injuries to the pelvis, partitional amputations or avulsions of the bone separation, lower leg, foot, or ankle injuries. Don't use those. You're mainly going to use this for like a femur fracture. That's where you're going to use those. The way that it sits underneath the buttocks and the way that it pulls traction is going to be specifically for the femur. Knee injuries, here you're just going to try to put the patient in a position of comfort. We don't have the ways to do any type of traction or reducing of those injuries in the field. We can medicate them and put them in a position of comfort. That's really the easiest thing that you can do for a knee injury. Let's see here. You will notice the swelling. You'll have some ecchymosis there, pinpoint tenderness to the site. If you've had anybody that you know has ever had a meniscus tear, ACLS tear, those are the kind of symptoms you're going to have. Oh my God, it hurts right here. It feels like a burning sensation. You want to try to splint that area, keep it in the most lateral, inline position that you can. So the splint should extend from the hip to the foot, stabilizing the bone above the injured joint to the bone below. So it's going to be a long splint. It's going to be a long padded splint. It's probably not going to be easy to pad them. You're going to have to put one on the outside and think about when you go to tie it. You're going to have to tie high and tight into the groin area, above and below the joints. And you never want to tie anything on top of a joint either. True emergencies that may threaten the limb. When the knee is dislocated, the ligaments that provide support to it may be damaged or tore because it can't support it in the position that it's in, so it may tear more as you go down the road. Always check for distal circulation before taking any further steps. The direction of dislocation refers to the position of the tibia with respect to the femur. position, inline position is what we need. Position the knee, posterior knee dislocations are common, occurring most in half of all the cases. A medial dislocation results from a direct blow to the lateral part of the leg. You may see these in football. Patients will typically complain of pain in the knee and report that the knee just gave out. Complications include limb threatening, popped arterial disruption, injuries to the nerve, and joint instability. If adequate distal pulses are present, splint the knee in the position in which you found it and transport the patient to the facility. Medical control may instruct you to attempt to relieve, realign the deformed pulseless limb or reducing the compromise, but that is potentially altering. So you need to reach out to med control before you do any of that. Advise them what you have and say that you have, I need, assistance in this. This is I need to know what we're, help me out, doc. Fractures about the knee may occur at the distal end of the femur, at the proximal end of the tibia, or in the patella. Management of the two types of injuries as follows. There's an adequate distal pulse with no significant deformity. Splint the limb with the knee in a straight position. Talks about the more of the knee. You never want to use a traction splint because remember that is a joint, and you don't want to pull it. You don't want to basically cause any type of separation there. If the pulse is absent below the level of the injury, suspect a possible vascular and nerve damage and contact med control. Let's see here, to the injuries to the dislocation of the patella. Splint basically here, splint y'all in the position of which you found it. If they're comfortable in that position, apply padded board splints to the medial and lateral aspects of the joint, and then go all the way from the hip to the ankle. Let's see here, injuries to the tibia. So fractures of the shaft of the tibia or fibula may occur at any place between the knee and the joint. Often both bones fracture at the same time. Even a single fracture may result in a severe deformity with significant angulation or rotation. So remember, it's going to be angulated or rotated side to side. Open fractures of the tibia are relatively common, so you're going to see those. These fractures should be stabilized with a padded, rigid, long leg splint or an air splint that extends from the foot to the upper thigh. Correct severe deformity before splinting by applying a gentle longitudinal traction. Contact med control. It's the best I can tell you there. Foot injuries, this is more of when they jump and land here, you're going to have a pelvic injury, and then you're going to have either a blown out heel. I forgot the heel pad. I've seen that one time. A guy jumped from about 15 feet and landed straight on his feet. He didn't do the tuck and roll. He paid for it later. Let's see, frequently the force of injury is transmitted up the legs to the spine, producing a fracture to the lower lumbar. So not only in this picture right here, this is where you're seeing the fracture in that little spot right there. So you're going to have multiple issues there. You may have a blowout of the tib fib and into the base of the spine at the same time. If you suspect that the foot is dislocated, immediately assess for a pulse. I want to know, do you have pulse and sensory? So you check for your PMS. If the pulses are present, immobilize the extremity using a splint, leaving the toes exposed to access neurovascular functions. If pulses are absent, contact med control on what to do next. Injuries of the foot are associated with significant swelling, but rarely with gross deformity. So it's not going to make you super sick, but it's still gross when you look at it. To splint the foot, apply a rigid padded board splint and air splint or a pellet splint, stabilizing the ankle and joint and the foot. Leave the toes exposed, so you can always check those. See if you have any swelling. You notice if any kind of pooling of blood into the area. When the patient is lying on the stretcher, evaluate the foot approximately 6 inches to the minimum of swelling. So you want to elevate that area. Here's your RICE. This is the rest, ice, compression, evaluation, and splinting. Elevation, get it above the heart to help reduce swelling. So amputations is, and then we'll talk about compartment syndrome, and that'll be it for you guys. So again, the best thing you can do for amputations is control the bleeding, apply a tourniquet high and tight. We don't do the over the joint. We want to always go high and tight. That is our ultimate goal, and that is what the studies and all the findings have made, that high and tight is what's going to best suit and save the patient's life. This allow us, we can apply another one later if needed. Surgeons today can occasionally attach the amputation parts. It just depends on where it's at and how long it's been amputated. Control any bleeding from the stump. If bleeding is severe, quickly apply a tourniquet. Get that amputated limb and take it. Well, there it is right there. Follow your local protocols. The goal is to keep the part cool without allowing it to freeze or develop frostbite. The amputated part should be transported with the patient to the appropriate resource hospital. I have had this happen before, that a guy ended up, I don't know what happened, but they attached the limb in the wrong position. So make sure you tell them, hey, this is his right index finger. Make sure you understand that, you know, I've seen it at our facility. Every medical facility is not perfect. They do make mistakes. So make sure you try to give that as much information as you can. Compartment syndrome, that does happen about 6 to 12 hours after the injury. You'll, as a result of severe bleeding, crush injury, and the rapid return to blood into an ischemic limb. So basically it's dying, and then you're gonna have all this rapid flow, and it's just not gonna G-haul like it's supposed to. So blood flow decreases inside a muscle compartment, ischemia results, and anaerobic metabolism results. Tissues become damaged and will die. The treatment is surgical procedures called as a fascinotomy, where they cut it open, they start working through there. An incision through the skin and the fascia allows swollen muscles to expand, reduce pressure inside the compartment. That is something that they do at the facility, and that's something we will never, ever do in EMS. Signs and symptoms, it's a pain out of proportion of the injury, pain on passive stretch of the muscle with the compartment and altered sensation. Additional signs may include pallor and decreased power. If you suspect that the patient has a compartment syndrome, splint the affected limb, keeping it at the level of the heart, and provide immediate transport. This is ones that you want to try to fly out of here. You want to get them as fast as they can. If they've been in a compartment syndrome for hours, anytime that the blood can return to the heart, it can create ischemia inside the heart too. That's it for the night, guys. I really want to talk real quick about Module 4. If y'all have noticed that the Module 4 is open, it is available for you to take. I know that we have one more module to go, I think, before Mod 4 is ready. We unlocked it the way we did because of our in-person class. They were able, they needed to take it. So I may need to go in there and extend the days a couple of times. So just remember, the same rules apply. If you take it and you don't do so high, you still have to apply by the regular syllabus rules on redoing a module test. If you would like to wait to redo that later on, that's completely fine. But I can have no issues whatsoever in extending the open time of the test until after Tuesday. So it's, again, it's there. We did it that way for the in-person class.
Yes, please. That would be greatly appreciated if you can push that out till like Tuesday.
Yeah,
I'll go in there and change the dates on there. Like I said, our in-person class, they've done a couple of different modules back to back, so they were a little ahead, and it was either hold us or hold them, and we just unlocked it in general. So I can change the dates, and then it's not a problem. It's super easy. I'll probably go and do that in just a second. Don't forget, folks. Hey, look, we've only got Thursday night is our last. That's it. We're over. We're done. I'll discuss more and more about the final exam. The closer we get to it, there's some difference in the final exam, but we will discuss that at a later date. I will not worry about that with y'all right now. Anybody have any questions, concerns, or problems you want to talk about? All right, Kobe, it's your favorite time of the night. There's your class code for this evening. Make sure you write that down, jot it down, take a screenshot, and that will be your class code. Good luck on your test this evening. Hope everybody has a great weekend. Don't forget, I plan on being traveling to go back to the rig. Hope to God they allow me, even though I have all this sinus stuff going on. If not, I will be back home Tuesday to talk to y'all from home again. I'm gonna mute my mic. If y'all need anything, y'all just give me a minute to unlock it. And all else fails, y'all have a wonderful night and safe weekend to y'all.
Go Longhorns.
Hey, Chris, do you plan on going back and looking in Discord about the message that I sent you about that one quiz?
Yeah, I'm gonna do that right now since you said something.
Okay. Last week was a rough week with me and kids and work. So I was a little out of sorts on today.
Yeah, I feel you. Give me